remind folks, I know a lot of times in institutions, these are two separate programs. The high-risk hereditary patients followed in one area and those with mucinous cysts followed in another. We've chosen to bring them together as a single population in our pancreatic cancer prevention program. And again, as George discussed yesterday, there's this population of patients for whom we haven't yet identified what their genetics are, but who clearly have an increased lifetime risk of developing pancreas cancer. And we follow those patients as well. An important member of our team are our GI genetics folks. And again, just keeping in mind that every patient that we screen with IPMN, we're carefully screening for this family history as well. And our genetics team, I think as George discussed, sometimes thank you, Gustavo. Sometimes those patients with IPMN who also we determine have a concerning family history, so we think about them a little bit differently, even though we don't have great data to guide us. And then we follow those patients dominantly who have IPMN, and the MCNs roll in too. But I think importantly here is this concept of it being a field defect. And in our program, we're not just screening the cysts and measuring the cysts, et cetera. It's looking at the whole pancreas every time, because oftentimes where they develop their cancer isn't actually in the cyst. It's in their pancreas, and it's simply a marker of a higher risk gland. So when I was at UT Southwestern with my colleagues in surgical oncology and gastroenterology, we developed a program, and then similarly now at the University of Wisconsin. And we spent a lot of time around what to call it. And at the end, I'll talk about how that's not as seemingly simple as it might be in terms of what patients hear. It's guideline concordant care. These are the guidelines that we followed. We found them to be the most rational. And I think importantly, throughout these guidelines, they emphasize the importance of the multidisciplinary team, which I think is really the value of programs like this. So here's our multidisciplinary team at Wisconsin. Importantly and critically, the RN navigator, APP team member or members to help, as you'll see, and particularly with follow-up patients, Surg-Onc, GI, 2 different teams in GI, our advanced endo team and our GI genetics, radiology, pathology, genetic counselors, our clinical trials team, and the patients have really been huge advocates for this program and have really spread the word. And we found the same thing in Dallas as well. So just to sort of walk through our protocol, because these were really meant to be sort of a how can I do this talk. Our patients are evaluated by our nurse navigator upon referral. A lot of those referrals come through. We've been really fortunate in both institutions to build with our informatics team an automatic notification. So at Wisconsin, it's called the pancreas anomaly notification. So any patient having imaging done for any reason, kidney stones, PE protocol, ultrasound, if there's any finding in the pancreas, it gets flagged to our nurse navigator through Epic. And so through that, if it's a solid mass, we refer it over to our pancreatic cancer program. If it's anything else, we bring it through this program, unless it's something obviously that needs to go to GI, like chronic pancreatitis. This is what this looks like. Again, this was a patient we just saw a couple of weeks ago, had a CT angio done for possible aortic dissection. And you can see here it flags as a pancreas anomaly. It shows up in the nurse navigator's reporting workbench in Epic. And this little message gets tagged at the end. This has been really important because it alerts the ordering physician or the PCP, but it also alerts the patient through MyChart. And a lot of times patients will self-refer as well when they get this flag or they see this flag. So again, it creates an opportunity for us to not miss these patients. From there, the navigator will, if it comes to the anomaly dashboard, will reach out to the ordering physician or PCP and just say, we're going to reach out to this patient unless you tell us not to. Does the clinical intake and gets the patient ready to be evaluated. All new patients are seen first by a physician, either gastroenterologist or surgical oncologist. We just rotate through the clinic and take turns seeing these patients. And all of those new patients are reviewed at a weekly multidisciplinary conference that we have on Wednesdays at noon. And the whole multidisciplinary team I mentioned earlier is there with respect to GI genetics, genetic counselors, clinical trials, et cetera. Our cancer genetics team is fantastic at reviewing all of the patients, and they frequently will identify patients there for IPMN that need a genetics evaluation. We screen we're part of the ECOG trial. We can screen for clinical trial eligibility, outline the plan, and then importantly, it goes into a conference note that has discrete data and Epic, so we can pull out all of that data into our dashboard, and I'll show you how useful that is. With our radiology colleagues, we have some tremendous collaborators there, and we've developed unique MRI protocols. Ironically, one of the fellows that was at UT Southwestern when I was faculty there, we recruited as faculty to University of Wisconsin, and so that's been a great collaboration with them as well. And obviously, EUS is a key. With respect to those patients who get EUS, we obtain cyst fluid and blood for both original research as well as for NGS testing on the cyst fluid. And for our high-risk hereditary patients, we really follow the CAPS protocol. Follow-up patients, and this is key, are all seen by our APP team members. So unless there's something concerning on follow-up imaging, and then they're referred back to the physician team members as appropriate. So again, the mainstay, of course, is MR and EUS and liquid biopsy. These two individuals have been fantastic collaborators. Mohammed Murtaz is a faculty member in my department who is doing some of the most cutting edge work globally in liquid biopsy space and has developed a new technology. It's just in science translational medicine called Galfrey. And so he's looking at all of these patients, in particular the high-risk hereditary, with his liquid biopsy technology. And Atul Singhi is a pathologist at UPMC and has developed this platform, which we are able to get on all of our patients. And this has really been hugely helpful at triaging patients into higher or low risk with mucinous lesions and being able to either escalate their surveillance or de-escalate. It is 20 million times better than Interpace, which is old technology, or Sanger sequencing, and this is NGS sequencing. So just briefly in the last minute or so, that what had happened. So this was sort of 1 year. I left, started January 2018, so I don't have follow-up data, but I know the program has continued to grow in Dallas. But even over just sort of 1 year's time, you can see the growth in patients coming in, again, through that radiology referral, as well as the genetics at UT Southwestern. Initially, about 25% were high-risk hereditary and 75% mucinous. And what we've seen in Wisconsin is similar growth. This is now kind of over 3 years. We're following, over 1,000 patients now, and it continues to grow. And this is potentially a challenge because we have a lot of patients to take care of now, and that's one of the things I'll mention. Our high-risk hereditary patients are a smaller percentage in Wisconsin, but that's starting to shift and change. And back to the kind of discrete data that we put in our conference note, you can see these are reports that I can pull out of Epic going forward, which makes it really nice in terms of being able to track this patient population from an informatics standpoint. And the patients come from all over for this program, and then they tell their family members, and then they come from even further away. So just, it's, of course, there are challenges in these types of programs, and just to share the things that have been difficult for us is that you have to do a lot of communication and planning. You have to build trust with your primary care team, and that's something I learned in Dallas and that went more smoothly in Wisconsin. They don't like it when you contact their patients and call them in for a test that they don't know about. Never would have occurred to me, but I appreciate their ownership of their patients and the fact that they want to make sure they're informed and part of that. So we really did a lot of work on the front end. The informatics build seems monumentous, but it absolutely can be done and has, again, been feasible in 2 different places. The name of the program, the Pancreatic Cancer Prevention Clinic, causes patient anxiety. But we've gone round and round, lots of other terms, and ultimately, this has worked for us because we get patients in quickly and focus on the prevention. And you have to have that RN navigator and APP support. The biggest challenge we have right now are these last 2 things, is making sure we're not having overutilization of healthcare resources by over-surveilling patients that shouldn't. We try hard to discharge patients from the program who don't need surveillance or who would never be surgical candidates or candidates for chemotherapy, and trying to figure out what our follow-up process looks like. So I'll turn things over to the next speaker. I do think we're at a place where pancreatic cancer prevention programs are no longer hype, but rather hope. And I think we can learn from each other and how to do this. Thank you so much.
Thank you. Maybe we'll have all our questions for the end. Our next speaker is Dr. Adam Yope from the UT Southwestern Medical Center, and he's going to speak about the development and implementation of an HII pump program.
Thanks so much for the invitation. This is a nice talk because I don't have to present any data whatsoever. So, because I think everybody's really tired of hearing the data with the hepatic artery infusion pump. I know D'Angelica and Litsky are probably freaking out that there's no data, but I'm going to show a lot of pictures, which is good for a simple person like myself. So I'm just going to literally show that now it seems as listening to Mike's talk and earlier today, really everybody is more interested in kind of the development and implementation of a pump program. And really, I'm going to kind of walk through this. My only disclosure is really I made every possible mistake that you could make when I started the program in 2009 at UT, and kind of walk you through how I made those mistakes, what to look out for, the little traps that you forget. I was very kind of biased training on the Upper East Side of New York because all of that stuff had kind of really been walked through in the pump program, was kind of very fine tuned, largely by Dr. Kemeny and her group. The pump program using hepatic artery infusion pump or infusion therapy is nothing really new. This has been around since the 1950s, and even over the last 30 years, pump programs have been in place in one form or the other. Really, you can see kind of the publication record, and that's kind of a good measure of how active things are, I think. Back in the, 1980s and 90s, there were, 50, 60 publications every year on hepatic artery infusion pump. Back in what I call the dark days of hepatic artery infusion pump was right around the time I graduated fellowship. So there was very little new to see there, but of course, coming out of fellowship, you're all full of excitement as you think you can change the world in the first week of being in a place. And so, of course, the first thing I did when I left the Upper East Side of New York and went to Dallas was literally said, well, I'm going to put together a pump program because that's what you need to do to draw patients in. So I think the two things that people do when they finish fellowship and they're interested in colorectal liver metastasis is they think, I'm going to build a pump program. I'm going to do the Field of Dreams model. I'm going to build this program and patients are going to come from all over the world to see us just because they're interested in the pump. I want to tell you right now, that's not the case. That truly is not the Field of Dreams model. If that's what you think is going to happen, it really is not. And then the second thing is what I've noticed over the last couple years as more people are becoming interested in pump programs, it's a marketing tool. These are, just doing a quick search on Twitter. These are the last tweets. It seems like everybody's the first program somewhere to do it. The first program on my street to do it. I think Mike, you had back-to-back tweets where you had the first Intera pump and then the next day, the first Intera pump put with a robot. Even the OG, Ron DiMatteo, got involved with the first pump put in Philadelphia. So I think it is a good marketing technique to build kind of access for your team. After the patients, what do you really need to get this going? And the excitement. The excitement, I think, is the most important thing because this is going to be a labor of love more than anything to get it going. I think the first thing you really need, or step one, is to get medical oncology buy-in. So it's kind of a well-known secret. When I first started putting in pumps in Dallas, I was the medical oncologist, the surgical oncologist, and essentially the nuclear medicine physician. I gave all the FUDR. I actually created all the beacon plans. I filled the pump myself. So that all changed with the kind of emergence of this guy on this picture, Ali Kazmi, who really saved me a lot of angst. So Ali surprisingly came from MD Anderson and said, I'm very interested in pumps. So I think probably Bote hadn't got to him, but he's been really a lifesaver. And I think to have a pump program, you really need to get medical oncology buy-in. You need to get at least one and preferably 2 or 3 medical oncologists who are 100% on board with having a pump program. The second thing you need to do, you need to go to New York City. You need to go to Bagel World on First Avenue and get yourself a bagel. And while you're getting bagels, you need to go and see Dr. Kemeny. So I think that I borrowed this from Sep Galami, and I think this is an incredibly important thing. There are people that are going to help you do this. And Dr. Kemeny cannot be any more cordial about this. The amount of phone calls that when I first started the program that went back and forth between me and myself. I mean, I'm not saying it was a pleasant phone call a lot of the times. I got yelled at a lot, but that was okay. And I think this is an important thing. I know that it helped out with SEP when she created her program at UCA Davis and now Northwell. It definitely helped out myself. She's seen it all. She's done it all. So I think she is a good role model for how to build the program. And then step 3 is really deciding on which pump you want to use. So up until, recently, about a couple years ago, the old Codman 3000 pump, that was the pump that we initially put in, was the pump of choice. There was some issues, kind of with the company kind of no longer making the pump. So everybody switched over to the Medtronic pump. I think everybody's back to the Intera pump just because of the one factor that the Medtronic pump is incredibly difficult to access for nuclear medicine. So that little tiny dot up there at the 12 o'clock position is actually where you have to do the pump study. It is damn hard to hit. And it caused a lot of consternation with us when we had to switch to Medtronic. So if you're going to do the pump, you have to use the Intera, essentially. That makes things so much easier. So if you're going to use the Intera pump, the next thing you do, you got to meet this guy. So he's sitting right there. This is a very nice picture of him. I have a much worse picture of him with the same picture where he's wearing a hat and sunglasses. But you got to talk to Spencer because he will make your life infinitely easier. He has seen it all. He initially kind of represented the Codman 3000 pump back in the day. He is a great resource for folks developing the program. So I can't encourage that enough. And then you really have to assemble your team. So there are a couple parts to this. I think the most important part are the two APPs in the left picture. That's Laura Sullivan and Faye Wright. So as I had mentioned, when we first started the program, I was the one filling the pumps. I was the one doing the pump studies. I was the one taking care of it all. And it really, as I got busier, it became too difficult. So what I was kind of able to do, and what they were very excited by, they do all of this for us now, which saves so much time. It also helped them, gave them more of a feeling that they were participating in the whole process. The second thing, you have to have good OR support. I'm not sure why Polanco got in that picture, but we will X him out. But the person on the far right in that picture is Kristen Steinlegge, who's our OR tech. So at this point, usually the Intera folks will come into your OR to help you set up the pump. Kristen doesn't really need that. And so it's been a huge boon to us. The second thing you need to do is you really need to have an IR and nuclear medicine involved. Simple things. The three-dimensional imaging right there with the reconstructions from a recent pump. When I first started doing this, they didn't do that. So I had to do it myself with Terra Recon and put it in the medical record. So it took a while to do that. They had really no interest in doing that. And then you need to have the nuclear medicine team on board because you're going to need to do the pump study afterwards. So that's my guy, Israel. Israel does all of our pump studies. He is absolutely fantastic at it and makes my life completely easier. But you have to have that on board before you actually start. And then you have to get a like-minded crew. So for the first 6 years or so, I really was the only one kind of putting in the pumps, definitely was the only one taking care of the pumps. And then so finally we have a group of about 6 of us who put them in. And so it makes my life a lot easier. And it also allowed us to now put in all the pumps robotically, which I think helps the patients out tremendously. So a couple silly things that nobody tells you. I know Mike Kavanagh gave a similar talk recently where he said the biggest problem we're finding these picks, the yellow things coming off of an appeal pack. And the reason why, I was like Mortimer Duke in Trading Places. I capitalized. I bought every single peel pack yellow pick that was available about 5 years ago. We have like 500 of them. So that's why Mike couldn't find any. And that was just a mistake that we bought so many, but it's the little things like that that nobody tells you. The second thing nobody's going to tell you, I mean, is the two different needles. We were on a call with a consortium, and one of the people on the consortium were like, I didn't know there were two different needles. It's because there's no way you would ever know that, because where you trained or where most of the pumps are put in New York, you never know that. But those are the little things that make the difference. And then to add insult to injury, you need to think about your pharmacy. Biggest issue we had was a glycerin problem. So if you want to fill the pump for longer periods of time, you have to fill it with glycerol. I said, oh, that's easy. Everybody, you can get glycerol no matter what. Can't get glycerol no matter what. It took a while to actually get that. So you have to think about all these things before you actually develop the program. So there's a lot of lessons learned. I think the main thing is this is not a field of dreams thing. This is it's really a tool and not an endpoint. You need complete institutional buy-in from all different collaborative services. You really can't be a lone wolf. So it's really hard to do by yourself. And then it's really a river of tears and a labor of love. There's going to be a lot of issues, but I think the patients are definitely worth doing this. And as we see from the picture here, this absolutely ridiculous picture where everybody's showing their muscles. You know, I guess that's what you do when you're a small person. You have to show muscles. I'm just looking around, as you see, looking at people flexing. This is from a picture from this morning from the pump consortium. So as Mike said, this is going to be a big thing going forward. And I'm really excited that he did this. This is courtesy of him. And so this will be a big thing for a pump program. So I encourage everybody to do it, but really reach out to the folks on this slide if you're interested in doing it. Everybody wants to participate and make this work. Thanks so much.
Thank you, Dr. Job. Next presentation is OS Leighton. Dr. Mariano Jimenez, Professor of Surgery at Buenos Aires.
Thank you, as I'm not a conflict of interest with this talk. Susan said today what is SOS HPV LATAM? Well, said SOS, help me AHPBA. But not only SOS, in Spanish, SOS. It's a conjugation of verb to be, and it's you are HPV LATAM. For that reason is you are HPV LATAM, and our association help you in case will be necessary. Latin American has excellent professional in the field of HPV surgery, but many times this professional is not working a team, working in the different cities. In every country, every city is totally different in Latin America. Some rich centers with the rich people and rich cities, and another is more poor. For that reason, is very important help all the people, all of our members. The other thing is the distance are great, and sometimes the surgeons may feel alone. More in case we have some complication or make when our member in Latin America has need some help in some decision with his patients. For that reason, is in sometimes the language, the English, etc., is a problem. And the another problem is the distance can be a limitation. For that reason, the idea is not our member move to us, is the HPB move for our members, move to our members. To create a system, this is the idea of SOS LATAM, that will be help our member and in Spanish. In case, for example, an academic question or a doubt in the decision-making of a patient, especially in case our member has not make the possibility to discuss the patient in the HPB multidisciplinary meeting, is not available in all the cities and in all the centers, postoperative complication or doubts in the postoperative management in very complex surgeries, and at the end of the day need for a e-mentoring or in sometimes e-proctoring for her practice. The idea is a very simple and confidential, has the possibility to use our member alone part of our web page in the SOS Latam, has the email and the question and the problem, data of the patients, images, etc. And our association moved the question to a group of experts with the idea to discuss very quickly and answer the question in the same way, or by email, or by mobile phone, or by WhatsApp, etc., the social media, internal, of course, with the idea to resolve the problem and help the people. Of course, this is an educational program, is not for the consultant, and will be in Spanish, and very soon the idea will be available in Portuguese. Repeat, this is an educational program. This program is intended to improve and enhance the quality of medical care in our members in Latin America. It is for HPB member only program. But our association has a strong commitment with the Latin American member. At this moment, around 20% of the member of the society. And we have SOS Latam is only one of the multiple possibilities to help. We create a chapter in every country in the continent. At this moment, we confirmed the last one in South America, Venezuela, and we work in the new chapter in República Dominicana. The other thing is for the economical problems. For example, in my country, Argentina, during this year, the inflation is 100%, a little more than 100%, a little more than United States. And really, for that reason, and with the idea to facilitate the possibility of the people come and participate in our society, what has a special price, not only for the member fee and the annual congress too. And really, it's a very fantastic effort to support our brother in Latin America. The academic and financial support to the HPB Latam Regional Congress. This year in September will be the Latin American Congress in September in Buenos Aires, Argentina, and next year in 2024 will be in September too in Sao Paulo, Brazil. Another help to our scientific research people in Latin America, the HPV foundations support with $15,000 to the winner of this scientific research. This year, won one research study from Chile, and we have 7 excellent candidates for this grant. 5 scholarships to attend to our annual congress, travel north, south, and south north for observership in medical institution. The outreach mission is some very important, Gassi Sibari start with this and continue several people in all the continent, in several countries, in Argentina, Paraguay, Peru, Bolivia, Guatemala, Nicaragua, El Salvador, Honduras, and Peru. And finally, SOS Latam is not the only action with our member, is one of the multiple action to collaborate with our member in Latin America. And the most important thing, I give you 2 minutes.
Thank you, Mariano. Nice talk. Next, implementation of clinical trials in community. Margot Shop from Orlando Health Cancer Institute.
Hi, good afternoon. Yes, so I'm going to talk to you really briefly about what we've gone through as we're trying to develop research programs in community settings. This is really what I had presented to my own executive cabinet about why research is important. I think sometimes the investment is something that you have to convince people of at first, because not everybody understands that research is not just an investment of money, but it's also an investment in our patient outcomes. And so what I told them is that research it's a necessary basic component of cancer care. And a lot of people don't understand that when they're trying to balance the books about why am I putting all this money into a research program. But I think explaining to them that this is for cancer care, this isn't an option. This is what we have to do in order to treat our patients appropriately and give them access to clinical trials, but it also improves patient outcomes and actually increases people want to come there because we have clinical trials, and puts our name on the map because we have clinical trials. So you all know this, but honestly, I'd be surprised that if you're in a community setting that your executive team probably is not aware of this. Research is not a four-letter word, and this is what I try and talk to them about. So if you look at this, you can see that, you know, across the country, only 70% of the patients live anywhere close to a place where you can get clinical trials. And actually, clinical trials are only open in about 1% to 2% of all the zip codes in the country. So a lot of patients don't have access to clinical trials. And this is why we're obligated in the community setting to be able to offer our patients clinical trials, just like anywhere else does. And so as you expand the access and clinical research, we bring clinical trials because people in the community, because they have to have them, they're closer to their home. They aren't going to travel for them, believe it or not. And the familiarity of the care team and the faculty, they want to stay there. It's interesting because if you look at some of the top components from surveys from Advisory Board and SG2 and other organizations, and they ask patients, survey them, what is most important to you in your cancer care in the community? And access to clinical trials actually is not even on the top 5. They're looking for subspecialists, experts in their fields, care all under one roof, docs that are communicating, navigation, but people don't really think about clinical trials until they need one. And so again, this is something that you have to have in mind when your administration knows that data, to understand, explain to them really the rationale of why it's so important. So the research pyramid is here, and it's basically giving patients access to sponsors, physicians access to patients. And one of the things that as you put together a business plan to put clinical trials in your offices, it's important for them to understand that many patients would not come there if you didn't have access to a clinical trial. And many patients aren't even eligible for the trials, but they'll stay because you have the trials available. This is hard to track, but if you could figure out a way to track that, I think that it would be really important. Multiple barriers that we have to clinical trials, as you all know about, is that people just have a hard time recruiting. And so again, we have to do our part as community physicians to enroll patients in clinical trial and continue to impress upon our leadership and our CFOs about the importance of them. Some of the largest barriers, again, there's travel for our patients, and many of them just aren't going to enroll in a trial if it means that they have to travel far to do it. Now, what you're seeing at some of these big cancer centers across the country, where you have clinical trials open for people with end-stage disease, that's different. Some of them will travel anywhere. They'll travel all over the world to do a clinical trial if it's the last-ditch effort that they perceive. But the majority of our clinical trials that we have open really are randomized clinical trials. They're cooperative group trials, maybe some pharmaceutical trials that aren't really going to be geared towards people who are willing to travel all over the world for. And Orlando Health, we have 11 hospitals and 9 sites where we offer cancer care. And 6 of these are really strategically placed so that we have full-fledged cancer programs where we have linear accelerators, chemo infusion, surgeons are seeing patients on site, and they're right next to a hospital. So we can actually give their care at the hospital with the 340B pricing. Of these, we really are taking our time to open clinical trials in the community programs, because you really have to be strategic about it and make sure you're opening the right trials for the right people. And trials are actually going to accrue patients. And so that's something that we've really thought about closely. And so far, we have our main hub, which is downtown, and we've opened clinical trials now on 2 of our other sites in the last 2 years. This takes time to make sure you have the resources that you need to be able to do that. So to initiate a research program in your area, again, it sounds really basic, but before you start looking into this, you got to make sure you have space for it. You need the equipment, you need the personnel, and the services. And I highly recommend that when you look into opening clinical trials, that don't try and take it on yourself as a surgeon, because most of the clinical trials we have open in cancer are not for surgery. And I'm talking about cancer and not just HPB. Most of them are medical oncology trials. And so in my experience now, this is the third time I've been running a cancer institute. And all three times we've been successful in our clinical trials office because we have a dedicated medical oncologist who spends about anywhere from 30 to 50% of their time just running the clinical trials office. And you have to find somebody who has experience. I think that's really, really important. And partner them with a dyad partner, a director who is not a physician, but is a director who really understands how clinical trials work, because you don't want to have somebody who's learning on the job when you're putting this together. It's incredibly important. We're lucky that we recruited somebody from Vanderbilt to work in our clinical trials office currently, and our physician who oversees clinical trials is Dr. Wasif Sef, who did the same thing. He was at Tufts, and then after that he was at Northwell Health, and he's now down in Orlando Health with us. So it really takes somebody who's experienced to be able to put this together. You have a lot of things that you need for your clinical trials that I have listed here that sometimes you don't even think about. You need regulatory coordinators, you need people who can put together basic SOPs. That's why it's really great to bring somebody in who's done it before, and they can bring with them all this information so they can get this started. I'm going to skip this. So one of the things, if you have not put one together, this is something that you should know about, is putting together an SBAR for your program and for your executive team so they understand the reasons for this. SBAR is something that's very straightforward. If you haven't seen it before, it's situation, background, assessment, and recommendation. I know my current organization, we can't do any program development without having an SBAR in place and a performer that follows it. But basically, you put together what is the issue with what's the problem, what's the background, what is the analysis that you put together with your financial team to show either a revenue loss or revenue gain? How long is it going to take before your clinical trials offices are actually breaking even? And how many pharmaceutical trials are you going to have to open for that to happen? Because it's probably not going to happen on cooperative group trials alone. And then, of course, the recommendation, which hopefully is to start a clinical trials office. That's a brief overview of opening clinical trials in the community. This could take, an hour and a half or a whole week to discuss on how to do this appropriately, but just high level. Thanks.
Next speaker, Matthew Walsh from Cleveland Clinic, development and implementation of virtual clinic in HPB surgery.
Thank you very much. I want to compliment everyone who's still in the audience, especially Dr. Kent, who must be exhausted. So I'm going to talk about virtual HPB clinics, and I have no disclosures. This is certainly an evolving tool that I think everyone in the audience is well aware of. It certainly has been impacted by the pandemic, the COVID-19 pandemic. And I would say probably the biggest thing to learn is, although there are resources other than in your institution, certainly having support within your institution is critical. You want to have a good interface with your EMR, since you want everything in your electronic medical record. We use Epic, which also we interface with Zoom, and we did change that over time, so things evolve. I think what I would highlight is there are many scenarios where you should consider this. We sometimes only consider it in the outpatient setting, but remember there are shared appointment visits that you can use this with. You can do it as for inpatient encounters, which is probably very important when you're talking about a systems approach, where you could see a patient in another hospital in your system, whether it's in, for me, Ohio or London or CCAD, and not have them come immediately as a hospital transfer, let's say, which may take twice as long. And then the reimbursement part has been an issue that is evolving. And I do think there are going to be some societal impacts, and I'm going to show you some data that one of my residents, who's a budding HPB surgeon, has put together. So I can share some things from our institution at the Cleveland Clinic through our webpage. There are resources that are available, which makes it quite helpful for us if you're interested in this. And we put out a dashboard that looks across our institution about the use and how many patients per month that this is utilized. You can see on the far right the number of virtual visits, as well as e-consults, which is a bit of a separate program for us. And we try and look at metrics on how easy it is for patients to utilize the platforms, because we obviously think that's important. And this is just to highlight that things keep evolving in this space. So this is an email to me just a week ago talking about how we need to make sure we have consensus as part of the Ohio law using virtual visits. And we have a dot phrase to utilize when we're doing that. And certainly around prescribing, that keeps changing. So whatever I tell you today may change next week. I think remote access interactions have a lot of advantages, and the things that are listed on this slide have been shown to be important, especially in terms of adherence to protocols, since you can touch base with patients quite frequently. The utilization of healthcare, people can actually get on and utilize it more likely. There are barriers, though. You do need the infrastructure support. There are patient concerns about being able to use the platforms and the technology, which are important. You need to roll that out as part of a systematic plan. And you have to have a fallback program. So you can use telephone calls as fallback, but they can't routinely be done because that won't be reimbursed. So what did COVID-19 do? There was certainly a proliferation of telemedicine and virtual visits, and that was quite important. At one point in 2020, 42% of all outpatient visit encounters were virtual. In terms of national acceptance, the Congress did pass the PrEP Act, which waived the licensure requirements that every state has. And there is a bill that I put on there that did extend the public health emergency around reimbursement to the end of next year. The expansion did lead to a lot of questions in terms of patients' attitude. And it has been interesting how it has continued or not continued in the clinical space after COVID. These are some data from this is just the surgery practice at the Cleveland Clinic, and over COVID, our virtual visits went from 1% to 11% of our outpatient encounters. And I just put this up. This is Cleveland Clinic data just to show you on the far left. For us, that's a Neuro Institute. That means where this has really taken hold is in psychology and psychiatry. So, and that is interesting in and of itself, but you can see the impact that it's had. And it does mean that across the country, those licensure requirements no longer apply to psych, which is interesting. So that's definitely here to stay. There are challenges around reimbursement, partly because it keeps changing since reimbursements around licensure in each state. And I think it's important that you do partner. Again, this is where institutional support is very helpful in how to document appropriately, especially around consenting. And we use time-based billing, which is very helpful. And I think if you include audits, so you know that you're doing it correctly, and your reimbursement specialist should be able to do that. You want to do this as a team, as this is probably going to go back to having specific state licensure requirements around it. And so we as a team within HPB have picked sort of which states in the immediate surrounding Ohio that each of us will have a licensure for, so that it's not just a random aspect. And there are certain things that you can do in terms of how you document things in the medical chart that will get reimbursed more likely if you do not make it specific to that patient and how you generally treat the patient. We try and put some things together that makes it easy for physicians as well as APPs understanding how reimbursement's going to occur, and these keep changing. This may be the single best slide for you, since this is the telemedicine website through the government, through HHS, which has great resources on it in terms of licensure and all aspects. This is just one of the pages off it around licensure. So since things keep changing, I think this is really a great resource. And this is just, so if you pull up, look for a doctor at the Cleveland Clinic, what we have done now is you can see on the lower right, which states they have licensure in, so that to make sure, try and get patients to the right doctor in terms of their televisits. And then there are guidelines. With COVID, some 60 guidelines have come out around virtual visits. And this is a summary of them, which was just put out this year. And many of these are obvious, but the consenting part is in there. How to make the best connections with patients is important. So there are guidelines out there to help you. I'm going to give you some general tips from an HPB and personal perspective. I think you should embrace these if you haven't already. I think it's a fact that they're going to be around. I actually think they're sort of fun. It is a nice way. Patients do truly like them. I think it is wise to pick the best patient groups. Post-op visits are ideal. Patients really enjoy that instead of driving an hour for a 10-minute visit. All of us are seeing a plethora of cyst patients, and a lot of them are being picked up on imaging, and this is a great way to assess them, to follow them. You can still have them get their imaging locally and you can see it, and they love that. If there are geographic locations that are difficult and it's a burden for patients to travel, I think it's great. Second opinions certainly qualify. I think patient preparation is very, very important. And so for new patients in our clinic that we think may struggle, we make sure they have the information, know how to use the platform. All of this in Epic is done through my charting, so they have to be set up. But there's a lot of instruction involved with it. I personally block out time in my schedule so that I'm not going back and forth. If when they're on, you have to be on too. You can't just make them wait, which we do in the clinic all the time. So blocking off time, I think, is very important. And lastly, I do think it's interesting that patients are voting with their feet, meaning many more patients have returned, even though we offer both inpatient and virtual. Unless they've gotten used to it, like the cyst patients, a lot of them still want to come in, which is interesting to me. Lastly, I want to finish up with Jenny Chang's work. So she has an interest in the carbon footprint, and we look just within our department on what kind of impact this actually is. And you can see virtual visits really do save patients money, and it does save the environment a significant amount of carbon burden, such that if you look at it, just on our results alone, 77 households would be powered for a whole year just by virtual visits. So in summary, I think telehealth is here to stay. It's really critically important to partner with your institutions on support and realize the impacts that you can have both for your patients and societies. Thank you.
So thank you to all of our panelists. Those were amazing presentations, and I've actually learned quite a bit during the session. We are at time at 6:15, but I want to invite anyone to come up and ask questions either at the mic, or if you'd rather in person, we can do that as well.
So I noticed 1,452 had surgery.
Mhm.
How many of those were cancers? I'm curious.
Yeah, so we're digging. Yeah, we're just analyzing that, and I didn't have it handy to put in there. They're definitely, now that we've been using the PANC-seq, it has helped our yield in terms of fewer low-grade dysplasia type of patients. Definitely have been some cancers and some high-grade dysplasia, and there still are some low-grade dysplasia, but I don't have the specific numbers yet. We have a fellow who's actually doing that right now. The great thing though is that we are able to pull that out of the dashboard, so we can pull all of their pathology and have that answer pretty quickly.
All right. Well, we are at time. Thank you all very much. you.